Today we're going to be talking about cerebral venous sinus thrombosis. Cerebral venous sinus thrombosis, but not everything about it, just neuro-ophthalmology of it. And so you need to know a little bit about the venous sinuses. So the superior sagittal sinus, the transverse sinus, and then the sigmoid sinus down the internal jugular. So when we're dealing with a thrombosis, it can be a superior sagittal sinus thrombosis. It could be at this connection point, which we call the torcula. It could be a transverse sinus, a sigmoid sinus, or the internal jugular. So these are the major draining veins that we are dealing with in terms of having a thrombosis, a blockage, in the venous sinuses of the cerebral system. And so for neuro-ophthalmology, the reason this is important is if you have a blockage in the vein that drains your brain, you'll have increased intracranial pressure. And so the imaging study of choice for patients who have symptoms or signs of increased intracranial pressure is an MRI with a contrasted MRV. And you need this V, venography, to find this V, venous sinus thrombosis. So if you just do an MRI scan, you might miss the radiographic feature of venous sinus thrombosis. So it's really important that we have an MRI plus an MR venogram in patients with papilledema. And so when we're looking at patients who might have cerebral venous sinus thrombosis, we're really going to be thinking about what are the symptoms of increased intracranial pressure: headache, double vision from a non-localizing sixth nerve palsy, and pulse synchronous tinnitus, or transient visual obscurations lasting seconds at a time from papilledema. And we're going to be looking for the signs of increased intracranial pressure, and in particular, sixth nerve palsy, non-localizing, papilledema, and a visual field defect. And on the radiograph, we might just see radiographic signs of increased intracranial pressure, fluid in the sheath, flattening of the globe, empty cella. But the key feature is going to be on the MR venogram. We're going to see the lack of flow in the venogram, and as opposed to idiopathic intracranial hypertension, which causes narrowing of the transverse sinus at the distal junction of the transverse and sigmoid sinus, in a thrombosis, the flow will travel and then all of a sudden the flow will stop. And so we need to look at both the MRI and the MR venogram because we can see the hyperintense signal intensity representing the clotted blood and the loss of the flow void in the affected sinus. And it can be in the superior, transverse, sigmoid, or the jugular. And so we really should be thinking about cerebral venous sinus thrombosis in three circumstances when it looks like IH. As you know, 95% of patients with idiopathic intracranial hypertension are obese young females. So if it's a thin person, if it's a man, if it's an elderly person, or if they have any risk factor or prior history of a thrombosis, including deep venous thrombosis or pulmonary embolism, these patients are particular risks of having a cerebral venous sinus thrombosis. And there's a 3-to-1 risk for women for cerebral venous sinus thrombosis, but you really should be thinking about IH in a man as the person who's the risk factor for pseudotumor. The 3-to-1 gender risk might be hormonal in basis, both the pregnancy and the hypercoagulable state of pregnancy, as well as the postpartum period, as well as hormonal replacement therapy, and of course oral contraceptives all increase your risk of thrombosis in females. So when we're dealing with cerebral venous sinus thrombosis, we need to think about it. If we have increased intracranial pressure symptoms, sign, or IH patients, especially atypical demographics, thin, elderly man, if they have a history of PE or DVT, MRI plus MRV. And we're going to admit the person to the hospital because we're going to need anticoagulation therapy. And I usually leave the anticoagulation regimen to the neurology service. Rarely there are interventional type things that could be considered, like thrombectomy, but usually it's a medically treated disease with anticoagulation. The only other thing I'll mention is Diamox, which is our normal treatment for pseudotumor cerebri, has some theoretic risk for causing dehydration, which could cause increased stasis in the Virchow triad. And so you really should talk to neurology about what the risk-benefit ratio is going to be for using Diamox in someone who has a venous sinus thrombosis. Of course, if they have an intracranial, parenchymal, or lobar hemorrhage, they're going to have symptoms and signs of the hemorrhage, seizure, stroke-like episodes, TIA, or hemiparesis, hemisensorales, the usual things from stroke, but on the venous side. But for ophthalmology, we really should be worried about our IIH patients and doing an MR venogram to rule out cerebral venous sinus thrombosis.